Hello and welcome to the webinar on hybrid dynamic models in COVID-19 planning and beyond. My name is Arash Mahdavi and I'm your host today. Today, as our guest presenter, we are thrilled to have Professor Nathaniel Osgood, who is a professor in the Department of Computer Science and an associate faculty in the Department of Community Health and Epidemiology at the University of Saskatchewan. Some of you who are familiar with Dr. Osgood's body of work know that he has a treasure trove of AnyLogic lectures on YouTube that have helped thousands of modelers, including myself, in their simulation modeling journey. In today's webinar, Dr. Osgood will discuss how classes of hybrid models can aid in more insightful, transparent, and nimble modeling in the context of unfolding uncertainties, with the COVID-19 outbreak serving as a central exemplar.
Welcome. I'm Nathaniel Osgood, Director of the Computational Epidemiology and Public Health Informatics Lab at the University of Saskatchewan. And I'm going to be presenting today a glimpse of some of our dynamic models to assist in strategic and operational planning and day-to-day guidance to help inform the prevention and the control of COVID-19 within our province. We're going to be spending the bulk of the hour going through model types that are consistent with the panel associated with this presentation, in that they focus on hybrid dynamic models, which lie at the heart of our modeling strategy for addressing the challenges of COVID-19 in our province. I should note before beginning that this work would not have been possible without the extraordinary assistance of our lab's many excellent graduate students, including those listed here. I want to single out Yuan Tian, Wade McDonald, Winchell Chen, Yang Chen, Liu Jiejuan, and Xiaoyan Li for their fundamental enablement of many of the lines of work here, as well as Dr. Kurt Kruger, a recent graduate from our lab and one of those who's most centrally helped shape the evolution of the modeling. I also want to provide my most sincere thanks to the Saskatchewan Health Authority in a partnership that has shaped this work from its beginning and that has allowed it to achieve its full potential. So within today's talk, I'm going to be providing an overview of the context of this work, and particularly highlighting some of the roles in which hybrid modeling plays a role throughout the different projects. I'm then going to go in to talk about three vignettes associated with hybrid modeling, which illustrate different uses of dynamic modeling to aid in the prevention and control of COVID-19 within our province. Vignette 1 focuses on use of models for capacity planning, but also supports some more detailed types of analysis, particularly with respect to fine-grained characterization of the acute care flows. Vignette 2 brings together a different combination of hybrid modeling. Rather than being confined to combinations of dynamic modeling techniques themselves, it combines dynamic modeling technique of system dynamics or compartmental modeling with machine learning and big data to allow for a dynamic model that's constantly regrounded in new evidence in a very fast-moving type of pandemic. That allows for daily status updates, short-term projections, and critically, what-if scenario evaluations to help us figure out, given the current situation and the best evidence for where we're at, what sort of policy enactments or policy portfolios will be most effective bending the curve over the next few weeks and months. Vignette 3 harks back to combinations of dynamic modeling technique, but does so to focus at a more detailed level than the previous two scenarios, and really looking at a fine-grained way, a very granular way, at evaluation of policy portfolios and the model involved has a very diverse repertoire of different policy portfolios that can be compared and contrasted to their many trade-offs. And finally, I'll be ending with some concluding remarks. So the context of this work lies, in, as I had noted, in CEPHL, or Computational Epidemiology Public Health Informatics Lab's COVID-19 program of work, conducted jointly with our health authority and through the leadership of Dr. Jenny Bazran, Senior Information Officer there. This work involves dynamic modeling as a central component, but is more broadly part of an advanced analytics program of work that cross-links such models with rich data sources, such as data from social media, from healthline mining, so mining from call data, for example, and from soon from smartphone-based data collection. Now, this work is purposefully centered around addressing key partner needs within our health authority, within our public health and acute care areas of that, but also within the Ministry of Health. And a set of partner needs emerged very early on in this work, including anticipating the possible set of acute care needs for capacity planning purposes that need to be mobilized to confront the challenges of COVID-19. Whether it's surge capacity on the human resources side or the availability of extra space to treat COVID-specific patients, they needed to know something about the level of demand that might be called upon for them in somewhat of a worst-case analysis. A second need related to really assessing the current situation. Where are we at? Are we at a situation where we're anywhere near herd immunity being attained? How many undiagnosed infected people are there likely out there? What's the effective reproductive number, the number of people infected by a given infective before they recover right now? There's also a need to accompany that understanding with short-term projections and understanding the effects of interventions in place now as to how bad things might have been without those interventions. And finally, there's a need to engage in very detailed prescriptive analysis for intervention portfolios to understand how to best relax the series of interventions that our work help stimulate, but also how to undertake new interventions in the dance phase of this, harking back to Stanford Professor Apoyo's work on the hammer and the dance. The dance phase involves really a fine-grained understanding of where things are succeeding and where they're failing, and being able to adjust the policy portfolio to reflect the need to ramp up protection in certain areas and ramp it back in other areas to allow for expansions of economic activity where possible, and to allow families to come together more readily, etc. So to address these challenges, within our lab, we've made use of 5 or 6 different models. I've listed them here because many of them are central to this presentation. I'm not going to dwell on this, except to emphasize that this list accords with our conviction, nay, our experience over decades, that to address these sort of needs requires different sorts of models for different sorts of questions, and different sorts of modeling approaches are needed to address those different sorts of questions. And as we'll see, some of the most powerful types of approaches are those that weave together multiple lines of different modeling approaches. Responsive to that, as we'll see within these presentations, we've made heavy use thus far in combinations of 4 different modeling approaches listed here. And a given hybrid approach, as we'll be going through with the 3 vignettes, combines together multiples of these approaches. Why do we engage in this sort of hybrid modeling? Well, I only address this in this presentation because of the topic associated with the panel. But the truth is, hybrid modeling is, in my view, one of the key methodological resources we can draw on for our projects. It allows nimbleness of modeling and adaptivity as our understanding of where the model needs need to be deepened or made in return more efficient, evolve. We can respond by crafting different areas of our models using different approaches. For example, compartmental or aggregate system dynamics models for areas which are of less focal interest, and agent-based or discrete event simulation for those of more fine-grained interest. We can also secure the very substantive comparative advantages of certain approach for certain questions. And for those who engage substantively in multiple types of modeling, it is beyond question that each of the major approaches, whether it's system dynamics modeling, discrete event simulation, or agent-based modeling, or in turn machine learning, each have their areas of extraordinary advantage. And we can tap into that. We can also make use of methods that appeal to and build confidence in stakeholders that can allow them to more easily relate their explicit and tacit knowledge, that can enhance the computational efficiency and support focusing our computational resources in areas that matter most within our models. And that can allow us to engage in multi-scale modeling with crafting of different models at different levels of the system. So having provided that brief introduction, I'm going to dive into the three vignettes, bearing in mind the limitations of time here. The first vignette focuses on a combination of three of the different modeling techniques, agent-based modeling, system dynamics, and discrete event simulation. This is work, parts of which were conducted through the generosity of the Health Quality Council on one of my doctoral students' time working there, although the model originated before has continued since then. This work centers on the need to anticipate the acute care capacity needs associated with the COVID-19 pandemic in Saskatchewan, reflective of an understanding of really realistically how bad could it get within our province. There's many aspects of this that I don't get into here, such as estimation of provincial basic reproductive numbers, but do draw on the approaches noted in some of the later parts of this talk. The goal here is to support capacity planning estimates, and to do that, we made use of an age and sex structure, age stratified model that describes COVID-19 transmission in Saskatchewan, but with a strong twist. The transmission module of this makes central use of compartmental characterization for the vast bulk of the population that's susceptible. But individuals are rendered into agents or are individuated at a point of the risk continuum, presently when they become infected. And from that, they can be rendered into agents, so they are exposed to other agents using contact matrices and mass action dynamics within the compartmental transmission model. But they can be rendered into agents once they are infected, in which case they can infect other individuals, they can flow in for care, and they can be discharged from care at a level of their particular characteristics and heterogeneity. So this includes a characterization of patient flow through the system, and a capacity to represent different regions within our province or indeed within Canada more broadly. This modeling makes use, therefore, of compartmental models or system dynamics models, agent-based models, but also discrete event simulation models to represent the service delivery components of the system. The population mixing model is used for the vast bulk of the population, keeping computational resource demands comparatively low compared to, say, a pure agent-based model, as will be featured last. Individuals start susceptible and can be exposed over time. We have individuals that can progress persistently in a symptomatic fashion. So there's a oligosymptomatic pathway to reflect the growing conviction among scientists that there are many individuals who persist in an asymptomatic fashion through their infectious period. Other individuals progress in a more traditional natural history of infection, becoming symptomatic, for example, over time. Individuals who are susceptible or exposed can be isolated or quarantined, resulting in their reduction of their mixing. Someone who's susceptible can be quarantined presumptively, say following a contact trace, may be protected against subsequent infection. But these are the key pathways on the right-hand side here that reflect infection of an individual. An individual also becomes infected here. And so doing, they flow into a series of workflows within discrete event simulation that lead them to be contact traced where appropriate, that allow them to progress and indeed allow them to enter acute care, where different levels of resource demand, including different types of ventilation, are called for. Individuals are subject to mortality, but many survive and are discharged. This representation supports capacitation in the form of explicit representation of resources, particularly key resources such as acute care beds, ICU beds, more specifically, and ventilator supplies. And we do have a representation which is at an individual level, allowing for very fine-grained treatment of patients, capturing of different distributions for treatment as possible within this model. The division of individuals is a familiar one for those who are familiar with the literature, with some non-oligos. So there's oligosymptomatic individuals, many of which go uncaught except by active tracing or active case finding mechanisms like screening or contact tracing. Individuals who are not oligosymptomatic, who do develop symptoms, can do so in mild, severe, or critical. And some individuals, particularly those classified as critical, are subject to death. There's some basic assumptions about the natural history of infection and timing associated with the flow here, and the level of resource demands and timing within ICU, and critically for that post-ICU rehabilitation period. These delays or durations are of great importance in that they can impose demand for acute care resources. It's not just how many people come in right now, but how long they stay that often can lead to bottlenecks that can lead to exceeding demands, and the model is designed to capture that very well at an individual level. Key outcome measures are not limited to, but do include the following, or outcome measures include the following: acute care beds, ICU beds, and ventilators. While many of our analyses have been conducted over 180 days, these days many of them look beyond that, reflective of the excellent job that our province did early on in containing the outbreak due to aggressive early action. So why do we engage in hybrid modeling for this? Well, there's a number of reasons. Comparative advantage. It's to represent resource constraints and the level of waiting for them, or the length of time under which an individual needs them. The language of discrete event simulation is an exquisitely accurate one. to capture the contact tracing process on individuals, it can be very advantageous to have an individual level representation of infectives. And yet system dynamics methods can provide a classical and very well refined and understood characterization of population mixing using preference or contact matrices as are used here. We also have different analysis needs. There are different questions asked in different areas of the system. For example, in the acute care side, we may be interested in PPE use, and a finer grained level of representation is called for, is advantageous. Another is adaptivity. By representing these three methods together, we can easily change the boundaries. For example, perhaps we want not just infectious individuals represented as agents, individuated upon flowing, reaching that level of the risk continuum. Perhaps we wish to delineate another difference in the risk continuum as motivating agency, as motivating individuation, such as people going in for being named as contacts or being a contact of an infective, in which case, when individuals are contacted by an infective, they could become an agent. We can shift the boundaries of this model in a nimble way to capture more detail, for example, a fine-grained individual level characterization of contact tracing if we wish to do so, if our learning pushes us in that direction or suggests it, motivates us. So adaptivity is a key motivator here for hybrid modeling. It's this ability to shift the locations of the boundaries as our sense of priorities evolve or needs for certain subcommunities. Another one is computational efficiency. By having this model largely simulating the vast bulk of the population at any one time is susceptible, meaning that the model can run very, very quickly for scenario exploration, and at the same time represents with a requisite level of detail or focal interest in infectious individuals and their acute care journey as well as their public health handling. As a result, we can get a best of both worlds. Great computational efficiency and rich understanding of the key aspects of the system about which we have the greatest interest. So that's Vignette 1, a model that weaves together agent-based modeling, system dynamics modeling, and discrete event modeling. I would note, following discharge, people stay represented as agents. So there is all three types of modeling. Vignette 2 is going to focus on a rather different axis or characterization. It's a combination of dynamic modeling in the form of compartmental models with machine learning. Responsive to the time, I'll have to go very quickly here, but I would note our substantive amount of resources on this topic, which are available. And some of my web pages devoted, just off my homepage, devoted specifically to this issue of these combined models. Here we're seeking to address daily reporting needs, understanding of where things are going in the short term, and understanding what the current situation is. Are we dealing with a situation where there are likely many yet undiagnosed infectives, perhaps asymptomatic individuals, or perhaps individuals who have simply not been found despite being symptomatic? And to investigate the impacts of interventions that may bend the curve in the weeks and months forward. These needs for constant adaptive replanning are acute in the dance phase of the outbreak, into which our province is now hurtling. And this model was designed with that in mind. So rather than a model sitting as a sort of a static representation of a discrete product that's developed and then used, it's really turned into a service with ongoing refreshing of the model estimation of the latent state, projection forward, estimation of the basic reproductive, the effective reproductive number that obtains right now, and the ability to ask what-if questions. We look to models here with the same expectations we might provide to the models that govern other aspects of our lives. Take a weather model. We may be using the most sophisticated weather model yet extant in the world to anticipate tomorrow's weather. But if it's doing so based on an understanding of weather patterns only as observed up to a month ago, and we're trying to anticipate tomorrow's weather, we're probably on a fool's errand, particularly here in the Canadian prairies. With weather forecasts, of course, we would never engage in such tomfoolery. We would make use of a model that's constantly regrounded with what's actually been observed, so that the same model renders far, far, far more accurate projections for tomorrow and the next day, etc., because it's been regrounded with the latest evidence. So tomorrow, the forecast for tomorrow, grounded for that same weather model, grounded with today's data and data on the recent past, is going to be far more accurate than if we had asked for tomorrow's weather as of a month ago. Or to view it another way, just like GPS systems constantly correct for where we're at and giving the recommendation of where to turn next, etc., we expect the same for our models. We expect, if we're being given guidance for models in a what-if sort of way, to be given guidance that's current, that reflects not just what the model thought would be the case now, but what's actually been observed. That it's regrounding a model understanding the current situation with what's actually been observed in the world, reflecting the fact that both are terribly fallible. So to achieve this, we have long turned to three primary strategies for combining machine learning on the one side and dynamic models on the other. And I list those strategies here. In each of them, we have publications in the peer-reviewed literature that can be readily found on Google Scholar or elsewhere. The one we're going to focus on today is the second one, particle filtering. And here we are seeking to estimate the latent state of the model, or technically sample from it, in light of all the evidence till now. And in fact, we're going to be sampling from trajectories, as we'll see, this x sub 1 colon t, for those for whom that notion is not off-putting. I'll also note that theta here is model parameters, m is the model, and y is the set of observations. We're trying to estimate what's going on right now out there in the population. And we do so, in turn, with a population of particles, which have these jockeying hypotheses competing to explain what's going on. This is a method which, if you look at my publication record, we've used in many other areas, most of them provided here. And I need to credit my longtime collaborator, Dr. Jushin Liu of the Department of Math and Stats at University of Saskatchewan, for her foundational work and helping to shape this work and inform our understanding of the methods, how best they can be used, and our implementation of them. So particle filtering is a deep process, and you'll find videos of me on YouTube holding forth on some of its more technical components for those interested in diving deeper. There's neither time nor topical space for that here. But a few key facts for how it works. Basically, the model involved has some stochastics, some uncertainty associated with it. In this case, it is a compartmental model, but there are some aspects of it that are evolving in an uncertain way. And this model, during normal operation, it just runs. For each particle, it runs forward in a normal way, but at observation points, the understanding of the model gets corrected. So within this context, when new data comes in, that data is taken into account, and we have an updated sense of what the current situation is. Much as with a weather report, we might, by glancing on it, have an updated appreciation for what's currently going on outside in our backyard. This is done in a computational, quite frugal way that technically is called recursive. It's incremental. Within this context, essentially we're running a compartmental model in parallel for thousands. In our case, we often use tens of thousands of particles. And each particle basically represents a different hypothesis about, at a given time, what's going on out there in the population right now. It is a complete sort of hypothesis about the current state of the system as represented in the model. And these hypotheses jockey to explain. They compete with one another to explain the empirical data. And there's a survival of the fittest of them. The particles that posit a situation in the world that turns out to be more consistent with the data, given the implication of that state of the world for what we'd expect to see in the data, those get rewarded. They get upweighted. So each particle is associated with a weight. And the particles that are more consistent get upweighted. Particles that are less consistent get downweighted. These weights are used to filter out particles that are too low a weight, that are just not responsive to the data, and allow particles that are to be fruitful and multiply. So conceptually, if we have an AnyLogic model, we're running it in parallel over tens of thousands of these particles, having them compete. Truth is, we do so sometimes for as few as hundreds of particles, but you get extra advantage for a larger number. So a lot of fancy talk here. What does this really give you? Well, it gives you the ability, ladies and gentlemen, to have a model that's constantly regrounded with new evidence, and that allows you to take in that evidence into account in understanding what's going on in the external world, how many people out there, for example, might be infected, and we don't know it. Or what's the effective reproductive number out there right now? How many people is an infecting before they recover? If that's greater than 1, the bug is going to be spreading. If it's less than 1, we're controlling it by and large. And there might be little, outbreaks here and there, but by and large, we're bringing it under control. And there's going to be fewer infectives over time. So it allows us to get a sense, for example, for what's going on out there right now. But it also allows us to get a sense of where we might be going in the near future. So, for example, the incident cases that might be coming up, or the hospitalizations that might be anticipated in the near future, the ICU demands. The model currently is more focused at the hospitalization level, but there's near-term extensions anticipated for ICU, and the model structure has been characterized for that already. In addition, a model like this, this method could be used to ask what-if scenarios, but what-if scenarios grounded by an understanding of where we are right now. For example, if there's comparatively few undiagnosed infectives, and indeed diagnosed ones, we might be more comfortable relaxing certain types of interventions. If the number of the degree of mixing in the population is still estimated to be low, we might rest a bit satisfied, but if it's getting higher and higher, we might engage in public messaging. So what-if scenarios can be based looking forward to ask what-if questions. Given where we're probably at now, and it gives a probabilistic estimate, what's likely to be coming? How does this model do this? Well, it learns over time, ladies and gentlemen. It learns from observations about factors such as the number of cases, broken down by travel status, the number of persons tested, number of persons testing positive, deaths. So this totality of evidence involving those. And right now we're just getting access to age-specific and regional-specific data, and we'll soon be tapping hospitalization data and ICU use. And it uses all of this, puts that data together into a consistent picture of what's likely going on right now and what to be anticipated going forward. So there's a variety of different variants of this model, including for different Canadian provinces, Canada as a whole, and some international jurisdictions. Key particle filtering elements here include separating travel from non-travel diagnosed cases, the representation of persistent oligosymptomatic pathways, so a pathway of persistent asymptomatics. Age and regional specific mixing is now possible due to the excellent work of doctoral student Xiaoyan Li, who's been the key leader through so much of our work involving particle filtering. Consideration of test volumes and positivity in the likelihood functions has been achieved, and we have parameter uncertainty captured with respect to evolving quantities, such as those related to presentation for symptoms, contact, and efficacy of testing. And there's a simple representation of contact tracing and screening as well. Okay, so important elements. This model ingests over time data involving cases, travel-related testing, and deaths. It has a very good behavior observed for many jurisdictions now, and it successfully detects shifts in the epidemiology over time. It also allows for ready estimates of the current state of the system and projecting forward and allowing us to examine interventions. One of the more interesting components is it allows backcasting. This is due to Xiaoyan's excellent work leveraging ancestry matrices from the particle MCMC literature to allow us to engage in sampling, not just cross-sectionally at a given time what the state of the model is, but sampling of trajectories over time. Which allows us to essentially consider later data and model dynamics to infer what was likely the case earlier. For example, case in point, what was the likely effective reproductive number before interventions began, which gives us a clue to the basic reproductive number. What you get out of here is sort of it could be thought of as population tomography. Some people watching this video, many likely, will be familiar with the idea of CAT scans or magnetic resonance imaging, MRIs. The strength of these methods lies not in the tremendous accuracy of any one image that they produce. A CAT scan, for example, image from a given angle will be taken from a given angle, and it will be, it'll have shadows cast by bones or stents or metal plates. It will have a limited field of view. Certain aspects of it will be blurry because of different focal considerations. But the real power is not the particular accuracy of any one image, but putting all those images together, each of which is terribly flawed, but together they illuminate a 3D view of what's going on within the patient's body. And so it is, ladies and gentlemen, with particle filtering in dynamic models. By knitting together many lines of evidence here, with an underlying theory of the model is captured through the underlying model equations. Here, compartmental models and some other work we're doing agent-based models. We can get sort of a 3D view of what's going on in the system that knits together all that evidence and all that theory into a consistent picture, a probabilistic picture, but one which evolves over time as new evidence emerges. So here we're observing from evidence over time and using that evidence to allow us to arrive at deductions. For example, and this is a 2D histogram in AnyLogic. We have time running on the x-axis. And on the y-axis is shown effective reproductive number. This is a 2D histogram. So at a given time, we could say where the dotted line is. We could think of this as slicing through this 2D histogram. And you could, if you follow that line, it will be a distribution along that line, indicating what the likely effective reproductive number was at time. In this case, it's around time 52. So this is telling us probably it's closer to 0.8, but it could be as high as 1 up here. This is of great interest to our authorities because if it's greater than 1, we're in trouble. The outbreak will likely be spreading. And so on a daily basis, these are recomputed. Soon we'll be doing this for provinces across Canada to provide them an understanding of how close we are to that knife edge, where things might be taking off, etc. We can also get, and as part of this 3D view, an understanding of the underlying count of undiagnosed infectives that are likely out there. This is aspects of the latent state of the system estimated by the particle filter. Or something about the number of people, the fraction of cases that are likely engaging in care seeking right now. In short, we can probe probabilistically some understanding of what's likely the case out there. And it's actually a joint distribution over the state of the model. This provides us a very powerful way of understanding the current context, but can then apply the basis for looking forward and understanding where are things probably going within the next week or two, given what we've seen to this point. A very important component that I referenced earlier is backcasting. So this consists of estimating earlier state in light of the later dynamics and in light of later evidence seen to the current point. So particle filtering is commonly used to cross-sectionally estimate, given all the data, say for time 30 here, given all the data we've seen to time 30, what's our effective understanding, for example, of the number of infectives out there, or in this case, how many cases of new infection we'd expect to see. In this case, we actually get a number, purple, which is below what we would have anticipated with the model. And the model corrects for that, and it does better in subsequent days here, say for quite a long time. It does quite a lot better. It gets corrected. The point is that we are estimating this distribution, say at time 30, in light of all the evidence coming before. But if we consider the evidence subsequent to that, how things actually went later, it probably tells us something about what was going on there at time 30. After all, if we had a big outbreak following time 30, it clues us into the fact that there's probably quite a lot of susceptibles and quite a lot of, at least a small number of infectives to get that outbreak started at that time. By contrast, if it were totally quiescent, there were no new cases for weeks, it probably tells us, if there were any infectives, they were very, very small number, and it suggests that the state a different interpretation of the state. Alternatively, you could suggest something about the number of recoveries. That's a very traditional way of using particle filtering. Well, what backcasting allows us, backcasting allows us to use that later information to understand what was the case earlier. And to do this, there's a mechanism of using ancestry matrices, and we sample from trajectories. Till now, each trajectory posits specific dynamics over time. And by sampling these trajectories from the latest time, we can sort of infer what was the case earlier consistent with latest evidence. So that allows us, for example, to go back and estimate the effective reproductive number going back in a way that takes into account all the subsequent data and dynamics which have been observed. Where these techniques are most effective, of course, is where they're combined with streaming incoming data that's always current, that evidences the model on a constant basis and allows the model to rerun. And my absolutely extraordinary master student, Lujier Duan, has taken the lead in hitching up these streaming mechanisms for our particle MCMC, as well as our particle filtering models, and doing so, for example, with AnyLogic agent-based particle filter models. When new data comes in, whether it's web scrape data from websites, database data, or data collecting interface from smartphones, etc., such as our Ethica epidemiological data collection system, that model can come in. It can be it can be routed around. It can be archived. It can be routed to particular models, and the models get automatically updated to the latest situation, and they can be used to ask what-if questions or project forward. Luce has undertaken this work to support automated particle filtering and particle MCMC using the methods of the sort described here. Luce has also extraordinarily accelerated many of those methods, such as for particle MCMC, for many models by dozens of times using GPUs, graphical processing units, to allow the models to run far quicker. And what that turns into means that we can conduct analyses, for example, with particle MCMC in a day that would otherwise take the better part of a month or even over a month. Or, alternatively, within a day, we can conduct much richer analysis, time boxed by a day, than would have been possible without this acceleration. Luce, through his extraordinary efforts, whether with AnyLogic models or particle MCMC models, with the streaming, has been a key component of this infrastructure to allow us to create automated reports on a daily basis for partners, which is an infrastructure shortly to be launched for partners across Canada, as well as for our provincial healthcare system. So daily reporting, daily updates to keep the models abreast of the latest evidence. So the motivations for hybrid modeling in this case predominantly were focused on comparative advantages of each approach, machine learning versus dynamic modeling, each complementing the other in extraordinary ways, and different analysis needs across the models. Machine learning, the inferencing, supports estimation methods. The dynamic modeling supports projection and what-if questions, counterfactual questions associated with those, and can do so in a way that each speaks to the strength of the other. Finally, I'm going to be speaking about the third vignette. This vignette, again, combines two types of dynamic modeling, agent-based modeling on the one hand, discrete event simulation, for detailed evaluation of intervention portfolios. That says evaluation portfolios. Apologies, intervention portfolios. So here we are combining agent-based modeling and discrete event simulation. This is a GIS-enabled ABM with a particular eye towards informing stakeholder understanding, including resource placement questions, as well as our ability to characterize remote and rural regions within our province and smaller communities, each of which having their own geographic context germane to intervention selection, such as community quarantining measures in our First Nations communities. This model supports and is supported by a wide variety of agent types. There's agents for persons, for those involved in screening and conducting the lab tests associated with processing the results of tests, say, for example, with PCR swabbing. For representation of long-term care facilities as agents, laboratories, community cohort facilities, contact tracing, operations, so tracing individuals within their networks to track down who may have spread to them or who may have been infected by them, for characterizing the operation of larger acute care facilities such as hospitals and long-term care facilities. It further involves a set of more passive agents that are still play an important role in the household, such as for mediating transmission, such as representing of workplaces, which may be closed or open, according to social distancing guidelines, households, schools. We also represent, for more technical reasons, test specimens and tracing records. So individuals within this model mix within households, schools, workplaces, and long-term care facilities. and also in hospitals. Individuals can become infected in any of those, including through nosocomial infection in hospitals and long-term care facilities. So there can be spread of infection, for example, to healthcare workers, or spread of infection to residents from a healthcare worker in a long-term care facility. This model is grounded by a set of data, some of which lies within our province, the source of which others lie outside of our province. And a central motivating factor, and indeed a rich source of insight provided by this models, relates to a broad set of fine-grained public health interventions, which it has been crafted to examine, whose trade-offs it has been crafted to examine. This includes many of the factors here. They are factors related to the impact of community cohorting, putting infectious people together in a single facility, contact tracing processes, and mass and targeted screening, but also understanding the impacts of school closures and workplace closures. Changes in community mixing compared to mixing that takes place, say, in workplaces, being able to examine that in a fine-grained way, where the mixing is taking place, reflective of the fact that different intervention portfolios may influence them differently, and different messaging strategies the same. We examine scenarios involving staggered rollback, for example, of workplace closures or physical distancing measures over time. We further have extensively looked at PPE use, and I should say we've looked at, I can't say we've extensively, but it's been looked at from the perspective of hospitals, community cohort facilities, but also in long-term care. And in long-term care, I want to highlight, this has been the first of our forays into more fine-grained representation of certain at-risk populations. So here we represent not just a blunt screening of all, but differentially resident screening versus staff screening, and closing facilities to visitors, restricting staff sharing between facilities to limit the degree to which a bug can spread through staff cohorting. And then also PPE use we examined. And finally, in conjunction with Alex Doroshenko and Karsten Hempel, whose work also joint with us, also helped to inspire some of the thoughts about model representation, representation of household sizes, etc. We represent the impacts of masks. Individuals within this model make use of a natural history of infection, similar to seen in some of those other models, including the possibility of persistent oligosymptomatic individuals. We also represent as a possibility the loss of persistent immunity. But progression in terms of status of infection is just one part of this progression. Additional agent behaviors relate to, for example, their diagnosis status, their care needs, and whether it motivates requirements for a ventilator, for example, an acute care bed. We represent, for example, whether they're isolated in a community cohort or under staff isolation, whether they're seeking care or not currently seeking care. This model, in contrast to some that we've built, has only a rather simple characterization of hospitals. A characterization that still is fairly articulated by the standards, certainly of compartmental or agent-based models, in that it captures a structured workflow that involves a number of checkpoints and considerations, for example, as to the level of acuity of a patient, etc. And there are capacitation limits provided for the resources involved. I will note that within these facilities, infection can spread. Currently, it's a limitation of this model that we're not currently reflecting those in capacity changes. For example, reducing the capacity reflected the fact that 2 out of 10 emergency room physicians have been exposed to COVID and have to isolate. But it is a significant opportunity to do so very quickly because they are represented there. Beyond the hospital, contact tracing as a process is represented. So we captured in a finer-grained way the process of finding individuals and getting them tested and waiting for their test results, etc. It is notable that inasmuch as we're seeking to characterize diverse communities, such as those in our far north, some of the aspects of this process may be very different in their timing. And the capacity of a GIS-based model, and one of its strengths, speaks well to this, that we can characterize, for example, for a small remote community, the unique delays associated with flying out samples for testing. And alternatively, for another scenario, examine the impacts of local kits that would allow that testing to be done, perhaps with different sensitivity specificity trade-offs locally. Healthcare elements, we do represent healthcare seeking. I mentioned nosocomial transmission, PPE use at different levels, and delays and testing that are associated with it. Lab testing has a limited capacity, or can be made essentially unlimited if desired, to separate that out from simulations. There are endogenous lab delays based on the volumes, and the delays impact diagnosis and reporting. So a model like this can be used. These are not latest results, and they should not be taken as the results of the model by any means, but I include them in here to provide some example of the types of things that a model could be used to produce. But for example, we could simulate dozens of different intervention portfolios and assess their impact, for example, on infections that take place, whether median, mean, etc., and examine the trade-offs between interventions as we relax certain measures, such as schools coming back into session or workplaces, and see to what degree interventions put in place fixes that stay fixed despite those relaxations, or to what degree their gains are subject to loss following the relaxation. We can examine this from the same model. These are just different summaries, different lenses being used on its outputs over time, representing, for example, many outcome measures in response to a baseline scenario and to an intervention scenario, which might posit certain types of relaxation of interventions. Again, these outputs are merely illustrative. They should not be taken as indications of what is anticipated, nor our latest results for our province at all. Quite the opposite. A big point of focus right now is representing key vulnerable populations. These include the homeless population, those those with mental health and addictions challenges. They have some overlap, but by no means, in light of today's traumatic economic environment, by no means are they mutually exclusive, nor are they entirely overlapped. Incarcerated individuals, we've had some good reach out from our Ministry of Corrections and Policing, with which we are eager to push forward some work. In Indigenous communities, again, having been grateful for some reach out there, but with the conviction that it needs to be undertaken in a partnership capacity. For elderly and aged care, we have a particular commitment as well that's reflected in long-term care, but we are proceeding towards representation of personal care homes and assisted care communities as well. And then the unique context of remote communities, which include, but are not limited to, many Indigenous communities. And finally, healthcare workers. Within the northern context, much of our interest lies on the housing front. Housing is a pervasive impact, social determinant of health, as my colleague Corey Neudorf has long emphasized. The impact of housing ramifies across an individual's trajectory, and indeed often across their lifespan. The impacts of crowding can impact transmission, to be sure, but also their capacity to isolate if found to be positive, physical distancing guidelines, the air quality to which they are subject. If an individual lives with 15 other individuals, several of whom are smokers, it almost dooms them, particularly in a context of our northern communities where ventilation is often quite limited, and the housing stock is poor enough to not allow that to be to really be very effective. The air quality can be really adverse in a way that could very materially increase the risks of COVID. Chronic disease and our travel requirements close things down. Chronic disease has potent risk factors. And the need for air travel can slow down testing, receiving back test results, limit the ability for contact tracers to come into town, can require long delays associated with getting an individual to the requisite acute care at a tertiary hospital. It can also, factors here can also, though, play into the potential for different types of interventions. For example, community-wide isolation may become possible for many remote communities, and community cohorting in a context of crowding seems particularly important. So hybrid modeling in this case has been used to secure many advantages. Comparative advantage of different methods in different areas, such as the exquisite ability for discrete event simulation to capture the resource requirements, and the slowdowns associated with differential levels of resourcing, different analysis needs across different parts of the model, to allow the model to evolve in a nimble fashion and to speak with stakeholders, particularly through the use, for example, of GIS type methods. So a few take-home messages. Diverse types of hybrid models can offer great value in planning for, preventing, and controlling COVID-19. Different models are built for different purposes, and it behooves us to build a different model, for example, for allowing us to estimate the current effective reproductive number and engage in short-term projection and what-if scenarios probabilistically than for detailed intervention selection, or indeed for the type of quick model that needs to be assembled for capacity planning. Interweaving of different types of modeling methods allows for these models that are at once transparent, they use the right mechanism for the right parts of the model, and mechanisms to speak to stakeholders for that area of the system. They are performant, such as with the capacity planning model representing most of the population, the vast majority of population who remain susceptible in a stock, in a compartment context. They are scalable. They can be more; those models can be more scalable. They can be highly effective at answering the questions for which they're designed. And indeed, they afford us a nimbleness and agility, which is much needed in this fast-moving pandemic. These methods are, moreover, synergistic with large-scale data collection, such as high-velocity versions of traditional types of data. For example, testing and case information and data from acute care, but also novel. And I want to highlight our keen interest in getting, as for many past models, are smartphone-based types of data collection hitched up, whether it's more research-based data collection associated with changes in contact patterns and mobility over time, or contact tracing. And moreover, being able to tap in social media and call volumes for helplines. Those who are interested in additional understanding on the hybrid model front may want to check out this URL as well. Ladies and gentlemen, it's been my great pleasure to be with you here for the past hour. I hope that work gives you a bit of a glimpse of the breadth and richness and depth of methods that we have used here to this point to confront the terrible challenge and scourge of COVID-19 within the Canadian context. It is my sincere hope that some of this information might help support work elsewhere to confront this modern day plague and allow us to proceed at once with policy portfolios that add life to our years, but also years to our life. Thank you very much for the honor of presenting, and I would welcome any reach outs for those interested in learning from or adapting elements of the types of models undertaken here. And I want to provide, once again, my most sincere thanks to all those who made this work possible, including Jenny Bazran at the Saskatchewan Health Authority, the Ministry of Health, and elsewhere at the Health Authority, and the work of the extraordinary set of Cephal students and Dr. Kurt Kruger, who have participated so centrally within this work. Thank you very much.
Thank you again for your time today, and thank you to Dr. Osgood for sharing his expertise and unique insights with the community. We really appreciate it.